Welcome to the EAU Podcast. In this special episode, recorded at EAU 26 in London, we present Dr. Giuseppe Magistro, Professor Gernot Bonkat, and Assistant Professor Kathrin Bausch, discussing the latest updates in the 2026 EAU Guidelines on Urological Infections. Join us as we embark on this informative journey.
Dear friends, welcome to the EAU 2026. On behalf of the editorial board of Urolots, Giuseppe Magistro is my name, and I'm glad to present to you two of my favorite urologists from Switzerland. So, grüezi miteinander. We have Gernot Bonkat, Alte Uro Basel, and we had Kathrin Bausch from the University Hospital in Basel. Thank you very much for joining us today.
A pleasure.
Everything will be about the EAU guidelines on urological infections. As we know, antimicrobial resistance is still on the rise, is one of the hot topics when it comes to healthcare worldwide. And here we have two experts today to join us and talk about the updates on the EAU guidelines. So guys, welcome. Thanks again for coming and talking about the new stuff. So my first question would be, what are the major updates?
Okay, if I may start, so Kathrin, please forgive me. Normally it's ladies first, but today I would like to take the opportunity to start with a big thank you to the community of urologists to EAU, because after 10 years of leading this fantastic guideline panel, I'm stepping back. And so I would like to take this opportunity to look back, but as well into the future. And Giuseppe, my old friend, you have asked me about the updates. And when I see or look back 10 years ago, then I would say that infectious disease in urology was more or less not so attractive like this today. When I leave now, then the guideline on urological infections is the second most downloaded guideline of all guidelines. The most downloaded guideline from non-cancer guidelines. And so I think this is a success, but this is not only a success, but this is reflecting the importance of this topic. And if I see now in 2016, the times were a little bit quieter, life was a little bit easier, but from our expert point of view, I think that during this time we were more or less pathogen hunters. So we have looked for pathogens and we have seen what is the easiest way how to kill them. And now we have made this transformation from pathogen hunters, seek and destroy, to more doing better things for our patients. So we would not like to harm our patients. We have seen that we have the microbiome and that even a single shot or a single course of antibiotic treatment might harm the patient. And in this direction, I would like to come to the update. Our guideline to update, it's not so easy because we have many topics, but I would like to mention three. So first of all, we have introduced a complete new chapter about fungal UTI, fungal cystitis. Kathrin will speak later a little bit more about it. Then we have updated our section on the treatment of cystitis, female cystitis, and there we have shifted more from the antibiotic treatment to the alternative. So we are mentioning different approaches how we can deal with this disease without antibiotics. And third, this what we can discuss later in detail as well, is we have updated the section on prostate biopsy, where we are more favoring, advocating the transperineal approach. So this would be the short introduction from my side.
So thank you very much, Gernot. On behalf of every urologist, you've done a fantastic, amazing job. 10 years. This is one of the most important guidelines worldwide, if I may say. And so it's really, really important that we continue this good work.
Yeah.
So let's get down to the nitty-gritty, as they say in London. So common problem in our clinical practice, cystitis. So my question would be, do we still have to treat it only with antibiotics, or are there new alternatives that might be also successful? What is the point of the guidelines?
So many non-antimicrobial substances have also been tested also against antibiotics, for example, against fosfomycin, which is used in the cystitis, and can be actually recommended to reduce the symptoms of a UTI and to prolong the UTI-free rate, not only for prophylaxis, but also for the treatment of actual infections.
And besides antibiotics, what is the repertoire containing that will allow us to prevent recurrent cystitis? Should it be always an antibiotic, or are there new weapons that we might use?
So interesting question, but make one step back, because we wanted to speak about the treatment of acute cystitis, and the prevention of cystitis, recurrent cystitis is another topic.
Yeah.
So let's start with the treatment of acute cystitis. Of course, we have the antibiotics, but now, as I said, we know antibiotics might not only do good things, they might harm our patients. And more young female patients coming into my office are saying, I don't want an antibiotic. What could you offer me else? And so we must say we have many options. So we have phytotherapeutics, we have painkillers, NRIs, which are working fantastic. And we have, of course, then other means like just wait to increase your fluid intake. But if you ask me, I think the painkiller option is a very good option if you would not like to go for an antibiotic. Of course, we have to inform then our patient that they have a slight risk to develop an upper urinary tract infection. So it's about 5% of female patients coming with a cystitis and a conservative approach, and they develop a pyelonephritis. At least we have to inform the patients. But all in all, it's a good means, so we have other options.
Especially for the young females with cystitis. Of course, not for the fragile older patients with resistance. That's another topic, of course.
And for prophylaxis, what are the alternatives?
There is not much new, I must say.
Yeah.
Increasing the drinking amount. We have been discussing the immunoprophylaxis over the last years.
Yeah.
Which is still recommended. Evidence for the other prophylactic measures is not very high. It's still recommended, like Timanose, cranberry. And I think you always need like a personalized option for each patient to discuss what has been done before, when do the UTIs occur. And this is what I personally do more and more in my consultations, that I try to personalize the management of these recurrent urinary tract infections.
Of course, we have these means, the Timanose and other things what you have mentioned, but we have some recommendations with strong evidence.
Yes.
Yeah.
But we should not forget, we have the estrogens, we have still the antibiotics, and we have the methenamine hippurate, which is a new player. It's not so new, but many colleagues do not use it because it's not available in their country. But from my personal experience, we can order it from the UK to Switzerland. It's working quite well. So I think this is what we have. We have a few strong recommended options to prevent the UTI.
That's an important point, dear friends. It does not have to be always the antibiotic first. There are effective alternatives. So it's important to counsel our patients and to use them. So this was one of the major updates. So you talked about prostate biopsy.
Yeah.
According to the guideline panel, what is the ultimate setting to do it right?
Yeah. So we are favoring since a few years the transperineal approach, and the literature is saying that we are right. So now we have more RCTs coming out, and if I just would like to cite three, I would not like to make it too complicated. But if you look at the translate, the ProBase PC and the prevention trials, then we've seen that there has been compared the transrectal approach with antibiotic prophylaxis against the transperineal approach without prophylaxis. And still, even in this scenario, transperineal biopsy has less infectious complications. So what should I say? If I ask you just from a doctor's perspective, what is the reason that we still use the transrectal approach? Of course, sometimes we have not the setting. And it's not that the transrectal approach is forbidden, But if you have, for example, a complication with the transrectal approach, you at least have to have some arguments that you say why you have used this approach. And if you use it, then I would recommend, according to what we have written in our current guidelines, then use a rectal preparation with a povidone iodine, then at least make a rectal swab, try to adapt the antibiotic prophylaxis to the swab. And this is against antimicrobial stewardship, but use an augmented prophylaxis. So all in all, it's still feasible, but I would suggest that we should now face the reality and start definitely to abandon the transrectal approach.
And if I might add, Gernot, that we also seen that literature is more and more showing that we don't need antibiotics in the transperineal biopsy.
Okay, that's an important point. So when we have to choose, the way to go is transperineal, and data suggests that even there we can spare antibiotics. So from the infectious point of view, definitely that's the recommendation in the EU updated guideline. And there was another chapter, something that hasn't been covered before. It's about the presence of fungi in urine. So what can you tell us about that?
So I guess in clinical practice, we see that a lot, and we quite often don't know what to do, especially in patients with catheters. Those fungi grow. Is it an infection? Is it not an infection? And as you could see in our research, probably only 2 to 11% of patients with fungi in the urine actually show symptoms, and those should be considered as a fungal cystitis. All the others are like an asymptomatic bacteriuria, just a asymptomatic funguria, and usually should also not be treated by antimicrotics.
So it's a common finding, and we should decide whether to treat it, yes or no, according to symptoms.
Exactly. But this is sometimes not really easy, because in which patients do we see fungal cystitis or fungi? Normally, especially Candida, doesn't adhere to the urothelium very well. So we need something else to induce the infection, and that usually is the catheter or another foreign body. So if a patient has a catheter, they don't usually have the symptoms we have when we have a urinary tract infection. So it is not that easy. Of course, we can rely on, for example, symptoms like fever plus the candida in the urine.
I see. When a patient is about to get an operation, let's say a prostate intervention, whatever, and he has the presence of fungus in urine, what would you suggest? Ignore it or treat it?
So there's three cases where you actually should treat the fungi in the urine. First is neutropenia, then newborns under a birth weight of 1.5 kilo, and before urological interventions, breaching the mucosa. So yes, you should treat that.
So according to ABU, asymptomatic bacteria, you should do the same with the fungus. So these are 3 new major updates in the guideline, and it's definitely worth a read. It's something you will need every time in your clinical practice. So thank you very much again for the excellent work.
Thank you.
To sum it up, we need to consider whether we use antibiotics, yes or no. In the case of cystitis, which is a common indication, there's a lot of potential to spare antibiotics. When we have to prepare patients for prostate biopsy, the transperineal route is the way to go. And in that case, also, EU data suggests that we don't need any prophylaxis in that indication. And if we find fungi on our pizza, that's okay. But if you find fungi in urine, you have to figure out if there is a foreign body, if there are symptoms, if an intervention is about to happen, then you can decide whether to treat it, yes or not. So thank you very much, Gernot, Kathrin,
Thank you for having us.
I hope there was something important, something new for you, dear friends. Thank you very much, and I hope you enjoy the rest of the Congress.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on the urological advancements, be sure to subscribe to our EAU podcast channel on your favourite podcast app. Until next time, keep learning and stay inspired.